Good night. I am Homid Fahandezh. I am a hand surgeon and a nerve surgeon. I work in Hospital Universitario Fundación Alcorcón in Madrid. And today we're going to talk about ultrasound scanning hand clinic. And especially I am going to talk about the utility of ultrasound in tendons. First of all, I would like to thank to Dr. Angel Bueno. He is an excellent radiologist that works in my hospital, in Hospital Universitario Fundación Alcorcón, for all the help and support. And also to my Avanfit team, Dr. Villanueva, Dr. Iborra, and Dr. Rodriguez for all their support in ultrasound since I began with this practice. As you know, there is a high correlation between ultrasound and intraoperatory findings when you have an injury in the hand. And I'm going to divide my talk in two parts. The first one is extensor tendon injury, and the second one is flexor tendon injury. Always for me, the anatomy is really important, and I think that the anatomy of the extensor tendons is more difficult than flexor. And as you know, the tendon go through the dorsal aspect of the forearm, pass through 6 extensor compartments in the dorsal aspect of the wrist, and then it will be in the dorsal aspect in the hand. For me, and I think that for all hand surgeons, it's really important the knowledge of the anatomy. If we know anatomy of the area where we are going to work, you will know where you are, and ultrasound will be really helpful for you. But if you don't know the anatomy, you will be like a blind person. You will be lost, and you will be really frustrated when you will start using this tool in your clinic. To show this is my PhD. It's an anatomical study of the adductor pollicis longus tendon and also anatomical variations inside of the first extensor compartment, looking for the correlation between the anatomy and the ultrasound. We studied different things in the compartment, the length of the extensor retinaculum, the presence of intracompartmental septums, the presence of the number of tendons and central slips that you can find inside of the compartment. And then after the study with ultrasound, we check it with an open dissection in 20 cadaveric specimens. We saw that there was a high concordance between sonography and anatomy in a lot of things of the study, especially in the length of the first extensor compartment, and also in one very important thing in clinic, and this is the presence of septum inside of the compartment. Here you can see an ultrasound of one of the cadaveric specimens where you can see the rosette sign, an hypoechogenic area between the two tendons of the extensor pollicis brevis and adductor pollicis longus tendon, and the same case with the open dissection where we can see here the septum before and after the release. Also, we can look for the number of tendons that we can find inside of the first extensor compartment, and also the distal attachment of the tendons in the trapezium, in the base of the first metacarpal. We are going to divide the first part of my talk in talking about the different diseases that we can find inside of the compartments. Starting in the first extensor compartment, the most frequent disease is the Decker vein disease. And how are we going to see this with ultrasound? We are going to see a thickness of the extensor retinaculum over the radial styloid. We can see also synovial fluid around the tendons, And sometimes we can see also vascularization of the retinaculum and the tendon. This is a case, a clinical case, where we perform an ultrasound and we saw the thickening of the extensor retinaculum, how there is synovial fluid around the tendons of the compartment, and how there is also high vascularity around, around the tendons in this patient. As I said before, one of the most frequent anatomical variation in the first extensor compartment is the presence of an intracompartmental septum. And here you can see, this is a paper of radiology, how we have a bone crest in the lateral aspect of the radius, and how there is an hypoechogenic area between the tendons of the extensor pollicis brevis and adductor pollicis longus. And also in Doppler, how we can see this vascularity in the retinaculum and also in the septum, and the correlation with the surgery, where we can find the septum that is really important to release. Sometimes we can find different situations. This is a case where we have a selective affection of the extensor pollicis brevis compartment. This is really important because if we want to put a shot inside of the compartment, or we are going to perform a surgery and we don't know this, and we open the compartment in the area of the adductor pollicis longus, our shot or our surgery will fail because we are not treating the main problem of this patient. This is a really interesting case of a Decker vein disease, and here what we are going to see is how there is a very strong and thickening of the first extensor retinaculum, how there is a extensor tendon rubbing inside, and also the deformity of the tendons passing down of the retinaculum. Another thing that we can find inside of the first extensor compartment are partial ruptures of the tendon. In this point, it's really important to know that we must check always the rupture in long axis and short axis. Why? Because in long axis we can see an area of partial rupture, you don't know the tendon that is affected. And this is in short axis, and here you're going to, and how there is a high vascularity inside of the compartment. That means that there is something that it's going on inside of the compartment, and that give pain to the patient. When we go to the third compartment, you can see many diseases. One of them is the infiltration of the tendons. This situation happens in patients with gout, and here we are going to see one situation where the tendon is normal distally, but then when the tendon of the EPL is crossing over the second compartment, you can see how infiltrated and thickened is the EPL. It's a very strange situation, but sometimes you can, in patients with pain and swollen in the dorsal aspect of the wrist, you can find this. Another situation that you can find, this is a case of Dr. Martinez, is a complete tendon rupture of the EPL. To see this, the best way is to look in short axis and long axis. And what you are going to see is that where the tendon should be, there is nothing. And proximally, in this case, there is a thickening of the distal of the proximal stump of the extensor pollicis longus when it crosses over the second compartment. So sometimes you don't see the rupture, but you see indirect signs that shows that the tendon is ruptured. Another utility of the ultrasound is in a patient with a complete tendon rupture of the EPL. Sometimes the patient, when you take out the splint, comes to your office and say that he felt one snap in the dorsal aspect of the wrist, and that he can move the tendon as before. So it's really important to check with the clinic, but also it's really important to do an ultrasound. In ultrasound, in static, you can see the distal tendon here and a very heterogenic area in the area where we had performed before the suture. But the best way to check the mobility and the function of the tendon is ask the patient to move and to do a dynamic study with ultrasound. And here you can see how the tendon, when you ask the patient to move, doesn't move correctly as one unit. This is a case of a 41 years old military service lady. She had a distal radius fracture 2 years ago, treated with a VOLAR plate, and 3 months ago she started with impossibility for thumb extension. She went to visit 3 surgeons, but the surgeons didn't say what's going on, what's wrong with the tendon. This was the lateral view of the X-ray, and this is the AP view of the X-ray, and you can see how in both there are long screws. The patient came with an MRI, and the MRI, the only thing that says is that there is a tendinosis, degenerative irritation of the tendons inside of the first extensor compartment, but they didn't say nothing about an EPL rupture. I performed in my office an ultrasound, and easily you can see how there is a long screw inside of the third compartment. And also we can see that in the place where the tendon should be, there is nothing. And also in the first extensor compartment, you can see the long screw that you can see very clearly in the X-ray, and the same you are going to see with the ultrasound, and how is irritating the tendons inside of the compartment. And of course, the tendon was ruptured, and we perform a tendon transfer. Another utility of the ultrasound is to check after tendon transfer if the tendon transfer is okay when the patient comes to your office. So how can we see tendon transfer of extensor index proprius tendon to EPL? The first thing that we must know is the technique, no? And if you know the technique and you know the direction of the tendon from ulnar and proximal to radial and distal, and you know that your suture with a pulver tab, you are going to do it at the snuff box, then with ultrasound, you have to reproduce the same things. So in the short view, you are going to see how the tendon goes from proximal and ulnar, here is the tendon, and goes distal and radial, and here we can see the area of the suture with the pulver tab. But for me, the most important view when you want to check a tendon transfer is the long axis, because here you can ask the patient to move the thumb, and you can see how the tendon is moving correctly in the dorsal aspect of the thumb. When we go to the fourth compartment, we can see here ruptures of the tendons, and here you can see a rupture of the most ulnar tendon of the extensor digitorum communis inside of the fourth compartment, and how proximally there is an infiltration of this tendon. Sometimes the patient comes to your office with a swollen in the dorsal aspect of the wrist. It seems to be a ganglion cyst, and what you find is a ganglion cyst infiltration of the tendons. Here you can see the proximal aspect of the tendon, the ganglion cyst, and a very fibrotic area in the tendon. The question is it working? Is it working, the tendon? So you have to ask the patient to move, and clinically you can check the extension and flexion of the fingers, but then you can see with the ultrasound, asking this, how the tendon is moving, and even with the infiltration, the tendon works. When you go to the sixth compartment, here there are many situations. The most frequent is the subluxation of the extensor calpulnaris, and another problem that you can have here is tenosynovitis of the extensor calpulnaris. It's really important to know that the position of the tendon will change with the position of your hand. And if you want to put a shot in a patient with pain and with a tenosynovitis, it's really important to be sure that your needle is inside of the compartment. For this, the ultrasound is really helpful. Another thing that you can look in the sixth compartment is the presence of partial ruptures of the extensor calpulnaris, and again, you must check this in both axes. Distally, now we are going to see in the Verdun zones. In the Verdun zones 5, one of the most frequent injuries is the sagittal band injuries. As you know, the sagittal band is going to stabilize the tendon over the head of the metacarpal. Here is the tendon, and here are the sagittal bands. When you have a rupture of a sagittal band, normally it's the radial sagittal band, what you are going to see is that when the patient make a fist and pass from extension to flexion, you are going to see how the tendon is going to subluxate ulnarly, comparing with the central situation in extension. So in flexion, you will see how the tendon subluxate in the ulnar aspect when the patient performs the fist. Distally, in the Verdun zone 3, the most frequent injury is the central band injury. And as you know, the central band attached in the dorsal aspect of the medial phalanx. And the injury that most frequently occurs is the boutonniere disease. So in a situation of pain in the dorsal aspect of the PIP joint after one hit in the finger with an acute flexion, we must suspect a boutonniere disease. For me, it's really important to do an X-ray and to check if there is a small bone fragment attached to the central band. Before I do the Elson test and other maneuvers that you can do when you suspect a boutonniere injury, I like to have an X-ray to be sure that there is no a small fragment. And this small fragment, you can see it also with ultrasound very well. If you don't have a small fragment, then you can do an ultrasound, and there is a small tip to see better, and is to put more contrast in the dorsal aspect of the PIP joint, put the probe over the contrast. Don't push a lot, so the distance will be higher and you will be better a small tendon like the central band. Distally, the most frequent injury is the mallet finger. It's a loss of active extension of the DIP joint. And here, again, you can have a small fragment attached or only the tendon. It's really helpful to see the normal anatomy. And what we're going to ask when we have a mallet finger, we're going to ask the patient to do flexion of the DIP joint, and we're going to see how the tendon moves together with the bone. But when you have a rupture of the tendon, you are going to see that you are moving the bone, the distal phalanx, but the tendon proximally doesn't move. Also, you can see in cases of mallet fracture, the small fracture and the proximal hematoma with the distal tendon attached to the fragment. Ultrasound helps you also when you can see healing in the X-ray, and in the ultrasound you can check inflection and extension if this fibrosis that you can see between the small fragment and the bone allows the patient to move without any problem of detachment of the tendon. So we can say very clearly to the patient at 4 weeks with this ultrasound, move, don't worry, you don't need to wear the splint 4 weeks more, and you can start your active flexion mobility, because we are sure that the fibrosis is enough to allow the movement. Be careful with cases like this. This is a very nice case of a mallet finger. It seems a mallet finger, but be careful when you see 60 degrees flexion of the DIP joint. Sometimes there are more things than a distal detachment. And this is a case of Javier de la Fuente, where we can see how the tendon is attached distally and the rupture is proximal in the dorsal aspect of the medial phalanx. This is the dynamic ultrasound, and here we can see the tendon distally attached and how the rupture and the hematoma is in the dorsal aspect of the medial phalanx. And this is the case during the surgery, and be careful with these cases. Always check proximally. Now we are going to pass to flexor tendon injuries, and anatomy, as I said before, is really important. I don't want to talk too much because we don't have a lot of time, but remember that there is FDS and FDP tendons, and also that we have the pulleys that are going to allow the tendons to be close to the bone, and also they are going to allow to have a very good range of motion in flexion, and they are this is why we don't see a bone stringing when we bend the fingers. As I said, if we have the anatomy in our head, it will be really easy to check it with ultrasound in both planes. There are two very important things to remember. When we have pulley injuries, the distance between the tendons and the phalanx will be less. Normally, the distance will be less than 2.5 millimeters in the A4 pulley and less than 3 millimeters in the A2 pulley. If you find a bigger distance between the tendons and the bones, please remember that probably you will have a pulley injury and then a bow stringing. This is a 43 years old patient. This patient fallen on his hand in extension and with the fingers with an important tension. He came to my office with a very stiffness PIP joint, and I suspect a volar sprain. But the patient came with an MRI, and this is the result of the MRI, where you can see the FDS and the FDP very separated of the phalanx. And I am suspecting here, as you know, pulley injury. So with ultrasound, can we check this properly? Yes. First, we must check the same finger, and we have to see that the distance between the phalanx and the tendon is 0.10, comparing with the distance of 0.43 in the A2 pulley. So it's bigger than 3 millimeters, so we have a complete rupture of the A2 pulley. But then we go distally and we can see how the distance also in the A3 pulley is bigger. So we can talk of a double rupture of the pulley in this case. In cases with a lot of stiffness in the PIP joint, sometimes it's difficult with the normal probe of the ultrasound to see in a good way the distance in long axis between the tendons and the phalanx. For this, it's better to use a smaller probe. Sometimes, especially in rock climbers, you can see patients that are climbing and suddenly they feel pain in the volar aspect, and they come to your office with a little hematoma in the dorsal aspect, in the volar aspect of the tendon, and the distance is less than 3 millimeters. So in these cases, we must think in partial ruptures, and they are really frequent, especially in rock climbers. This is another case of A4 pulley, complete injury, and here you can see that the distance in the long axis is 0.34, and how we can check also with dynamic flexion how the tendon separates, comparing the relaxing situation and the dynamic flexion, again strength, how does the tendon separates from the bone. This is a case of a hand therapist that works in my hospital. He's a big man and works very hard with the hands, and he came to my office 15 days after a small injury because he has pain in the volar aspect of the thumb, and he says to me that he feels like he was losing the strength in his thumb. I suspect in this case a rupture of the pulleys, and I perform an ultrasound. This is the normal thumb, and this is the normal distance, 1.2 between the phalanx and the metacarpal and the FPL. And this is the injury site where we see that the distance is of 4.9 millimeters. So there is something going on here that allows the tendon to separate. I like very much to do the test in contraction and with the patient relaxed in the transverse and in the short axis plane. And here you can see the normal situation in relax and how the tendon separates from 5.4 millimeters to 8.1 millimeters with contraction. And this is really helpful to do the diagnosis. This is the patient during the surgery with the fibrotic, and here you can see the bowstringing of the FPL. Another pathology that we can see really often in our clinic is the trigger finger. Here, this is the normal anatomy. The tip to check the A1 pulley is to look always the MCP joint, and always in the volar aspect of the tendons, you will find very well the pulley. When you have a trigger finger, my recommendation is to do always a long axis first to check where is the pulley. Here is the MCP, and this is a very important case of a trigger finger where you can see a very strong thickening of the pulley and how the tendon has this rubbing and deformity. Always check in the short plane because sometimes you can see better the thickening in this plane. I like always to play with both axes. Not always a trigger finger is the cause of limitation of flexion of the fingers. Sometimes we can find, like in this patient that has a psoriatic arthritis, a patient that has problems to flex and to make the fist. And in this case, what you can look here is the difficulty to flex the fingers that has this patient, and also she has a CTS of this hand. When we perform the ultrasound, we can see very well the tenosynovitis in the flexor tendons, all the way of the synovial area where the flexor is covered has a lot of tenosynovitis, showing very well even the areas where the pulleys ends. And if we go proximally, you can see also this tenosynovitis and how in the carpal tunnel we have a very strong tenosynovitis that gives the patient the symptoms of a CTS. I perform in these cases with Walland a synovectomy, and then I did with Walland also a CTS release. The Walland will help you to check in the OR how the movement of the patient during the surgery. And also it will allows you to show to the patient the result, and then it will help you very well to have a good result in the clinic. This is the patient after 2 months, and here is the flexion mobility of the fingers. And you can see also all the scars of the surgery. Another very important thing in flexor tendons are the tendon ruptures. You can have tendon ruptures of the FDS or the FDP. Here is a case of a tendon rupture of the FDS, and always please check in both axes. This is a case of a complete injury of the FDP tendon, and this is a very typical injury in sports patients. And in normal situations, when we ask the patient to do one hyperextension at the tip of the DIP joint, you can see very well how the tendon moves together with the bone, with the phalanx. But if you have a complete tendon injury, you will see one hematoma, and you are not going to see the tendon moving proximally. This is a very interesting case of a rock climber. This patient came from another surgeon that performed an ultrasound, and the surgeon said, Homid, I sent this patient because this patient has one rupture of the FDP tendon at the base of the distal phalanx. When I performed the ultrasound, I saw something that was attaching here. So there was some tendon in place in both sides, the ulnar side and the radial side. And also I saw that the tendon was of the FDP was not at the A3 pulley, and that the tendon was in the medial aspect of the proximal phalanx. So I went to the surgery with Walland also, and this is what I found during the surgery. This is the distal stump of the tendon that was really injuring. And also this is the proximal stump. And the ultrasounds help you to check and to have a good view of the problem that you are going to find, and also allows you to have a better strategy for your approach. And again, I like Walland for this, and I perform the suture of the tendon. Another case of Dupuytren disease. This patient was a lady that has a selective fasciectomy. She had one infection, and while she was in the hospital taking antibiotics, she felt one snap. She came 18 months later to my office, and it was the situation. The patient couldn't bend and couldn't do a right flexion of the third finger. So in this situation, you can think about a rupture, or you can think also with a lot of fibrosis around the tendon. So ultrasound in the same moment helps you to see the normal anatomy of a tendon, where you can see a very good gliding of the tendon inside the digital channel, and also helps you to check the mobility of the tendon inside of the pulleys. And you are not going to see nothing of movement, even I do a passive motion. So in this situation, you have to think about a rupture or adherence of the tendon. And here you can see the tendon rupture in this plane, but especially in this case in the short axis, this is the normal tendon, the normal appearance, and you can see here this image, ultrasound image, where is pathologic. There is a big distance between the phalanx and the tendons, and there is a lot of fibrosis around the area, and how separate is the tendon. So we can say that this is a rupture of the tendon, and we must do this procedure in a two-stage technique of reconstruction. So it's helpful also. Finally, this is a case of a Dupuytren disease. It's a 74 years old man. We use CAPS for this case, and at 24 hours after the infiltration, the patient felt one snap at the finger, and he came to my office with the finger in extension. So I thought that the tendon was ruptured. This is what I found in the ultrasound, the tendon proximally, but distally there is nothing here in the long axis. If I check in another plane in the long axis, I look a very heterogenic area of in the tendon with a very bad aspect. And in the short axis, it helps me a lot, because this is the normal distance, and here you can see how how degenerated is the tendon here, and how when we go from proximal to distal, we are going to see that the tendon will be ruptured. Here is the intrinsic lumbrical muscle, and here we don't have tendon. So we are sure now that the tendon is ruptured, but we will know where the tendon is ruptured. So it will be easier for your approach to see the tendon and to do your surgery easier. So to take home, I think ultrasound is a good tool for diagnosis. It's a reliable and cheap technique. I think that to do ultrasound, the anatomical knowledge is really important, and I think that ultrasound is really helpful in your office because it will help you in that moment for the diagnosis and treatment in a very easier way, and you don't have to send the patients and then the patients have to come back. I think it's a dynamic test, and this is really helpful, especially in tendon injuries, and also helps you for surgical planning. So because allows you to see before opening, and I think that is a good point. Thank you very much.